Today we have the SOFT founding professional. He is the SOFT medical advisor. He's near and dear to all of our hearts here at SOFT because he has always advocated for kids with trisomy syndromes, and so we appreciate him a lot. Dr. Carey is now Professor Emeritus from the University of Utah. He is continuing on with mentoring doctors and continuing to work with SOFT. So we really appreciate that he's here to speak with us today. And I will turn it over to you, Dr. Carey.
Thank you, Kelly. And I want to acknowledge both Terry and Kelly for the incredible job they've done this week in orchestrating the professional talks, as well as the talks for the parents and families and the other events that were still upcoming on Friday night and Saturday night both. So take a look at those on the schedule as well. And again, thanks for everything you've done. So I appreciate the opportunity to deliver my now favorite presentation. This is something that I've had the opportunity and privilege of doing this particular talk at various medical forums and children's hospitals that SOFT has visited over the last few decades. And as you can see, my talk will be on the perspectives on the care and management of children with the trisomy 13 and 18 syndromes. My purpose is to identify the important themes in care and management of a child with these important and complex conditions, and to provide you a summary, it'll be rather concise, of the phenotypes. Even we'll talk about some of the survival data and the developmental outcome of persons with these two syndromes. At the end, I would hope that you will be able to list the important and distinctive manifestations of trisomy 13 and 18, summarize what is known about the outcome, especially the developmental and health outcomes, and to identify key themes surrounding some of the controversies in the care of infants and children with the two syndromes. And I'll talk in the very beginning about some of the basic issues of this so-called controversy. But first, I would like to say something that Kelly alluded to, being founding professional. I've had the privilege of being involved in SOFT since its creation in 1979 here in Utah. I was taking care of a 2-year-old young lady. Carey Holiday was her name. You'll see her picture in a few minutes. And that led to conversations with her mother, Chris, that eventually led to the establishment of SOFT. This is actually a picture of a very nice brochure card that we have that shows a lot of the infants, children, and adults, poster children, poster people for trisomy 18 and 13. But I would like to add that this experience that I've had, this honor and privilege I've had, have probably given me a somewhat different perspective, somewhat different worldview in how we look at these two conditions and perhaps how they're often looked at generally by my colleagues. So here is an outline of the talk. I'm going to continue with a background that's going to list 3 premises and then leading up to 3 timely questions. Most of the talk will be on the natural history and medical manifestations of trisomy 13 and 18. And I will close with, again, a concise discussion of what I think is the best model now for approaching care and the goals of care, and that's a shared decision-making model, which, as you know, many people are talking about that particular label in healthcare more than they were a decade ago. So here are my basic premises, and that is that the conventional wisdom surrounding the care of newborns and young infants, especially with the two syndromes, has been non-intervention, not including technological support, and going down the path of comfort care. I think this is really in the United States, and I think even in Europe, almost part of the culture that surrounds the care that occurs in both our prenatal and our postnatal settings. And I'm going to talk about maybe a different view of that, not dramatically different, but just a different way to look at that as we go along. I would suggest to you that starting in around 2006, there has been an emerging dialogue that's quite rich and quite scholarly, that's in the medical literature, pediatrics, genetics, and bioethics, that really talks about looking at these issues about this conventional wisdom in a different way. I would suggest to you that there has been some shift in the paradigm. One of my neonatal colleagues, Peter Hulick from Denver Children's, actually said that the sort of what's surrounding the care often, especially postnatally in the NICU, is almost a palpable tension. Again, we'll talk about that more, and I recognize that I could be oversimplifying the complex issues. But part of the emerging dialogue was a paper that appeared in Pediatrics in 2008 by Drs. McGraw and Perlman, where they did a survey study of neonatologists in New York State. And in this survey, more than half of them indicated that if there was a prenatal diagnosis of trisomy 18 and the child had difficulty in the delivery room, that they would not resuscitate. Of course, this is a survey, and we don't know if people would act the same way that they answer a survey, but at least gave you a sense of what that majority said at that particular time. After the paper came out, Dr. Scott Showalter, pediatrician in Denver, also the father of a boy with trisomy 18, and myself wrote independent letters to the editors commenting on this article and mentioning that the issue of the best interest standard of care, which they were promoting, is not so always easy to define. Also, in this with the trajectory now that I'm going through about this worldview and how things may be changing, I wrote a paper in Current Opinion in Pediatrics, appeared in 2012, and it summarizes a lot of what I'm going to say today. And that paper was subtitled Striving for Balance. And so that paper and a lot of its previous references will summarize the talk. Another seminal paper that also appeared in Pediatrics the same year, written by Annie Janvier, Barb Farlow, and Ben Wilfon, was the reporting of a survey that they did with families of trisomy 13 and 18 using social networks as their platform. And this was maybe one of the few studies, there are a few others, one of the few studies that kind of gave us a sense or a reflection of how parents, where they were, even with the challenges of a child with a complex medical condition that threatens life. In fact, in many of the parents of the children in the survey, they had already lost their child. But one of the key points that came from this story of the paper was that the parents related that there was really a joy in the care of their child and that they really felt that their children were happy, even with all of the challenges. Another important paper in this dialogue, this is kind of laying the groundwork for you, by Dr. Lorenz and Hardart, also appeared in Current Opinions in Pediatrics a few years after mine. I think was one of the best sort of laying out of an approach to counseling families as they reported the evolving, really the change in what was occurring in medical and surgical management. And I'm going to go back to this paper because I think they did an excellent job in laying out the issues, the key issues, the centerpiece of what would be called this controversy. And lastly, in the way of introduction, I turn your attention to Dr. McCaffrey, neonatologist from University of North Carolina's interesting paper in 2016, where he actually makes a parallel that what we're experiencing now as we look at care, think about other models of care in trisomy 13 and 18 is similar to what was happening in the 1970s and 80s in the care of children with Down syndrome. So I just point out that parallel that Dr. McCaffrey brought out. So that's kind of laying a groundwork for you in the way of background to kind of say what could be some of the root of what is the issue surrounding the controversy in care. So I'm going to pose 3 questions now. These are the same 3 questions that I posed in the paper in Current Opinion in Pediatrics. And then I'm going to spend the next 40 minutes trying to answer those questions to the best of my skill. And those questions are trisomy 13 and 18 uniformly lethal? I'm not going to have much time today to talk about the variables and outcome, but that's another important topic. Second question, what is the neurodevelopmental outcome of older children with trisomy 13 and 18? And again, I'm going to detail more about what is the basis of the controversy, the sort of approach to non-technological interventions, and so on. So here, the next part of the talk will be the central part, most of the bulk of the information we're going to share. And this is the natural history of trisomy 13 and 18. I'm going to discuss trisomy 18 first, only because it's more common than trisomy 13, and then I'll discuss trisomy 13. But these 2 important congenital syndromes share 3 important common areas, and that is the increased predisposition to medically serious congenital malformations, especially of the heart. About 80% of children with trisomy 13 have a structural heart defect, and over 90% of trisomy 18. And of course, the heart defect enters into all of this discourse. Secondly, in both conditions, there is an increased neonatal, first month of life, and infant mortality, first year of life. And I'm going to share with you some of those figures of survival and mortality that have come from population studies going back 3 decades and some of the important new work of recent years. And thirdly, what they also share is that the outcome of surviving children into infancy, toddlerhood, and later is to have a significant developmental disability, quite similar in both conditions, and we'll talk more about that. So let's discuss trisomy 18 first. Trisomy 18 is the second most common autosomal trisomy after trisomy 21 Down syndrome. The live-born prevalence, that is children born alive at birth, is the best estimate, is about 1 in 6,000. There you can see the range of the larger studies. Trisomy 18, like trisomy 13, is a recognizable pattern of medically significant and minor phenotypic variations, the increased neonatal infant mortality, as I mentioned, and the psychomotor disability. Those are the key components, as we already had said. The manifestations that are most consistent include the baby being small for gestational age, somewhat similar facial features, characteristic posture of the hands, short breastbone, and as mentioned, the medically significant malformations, which I'll review concisely. So here is the first young lady reported with trisomy 18 in April of 1960 by John Edwards and colleagues at Oxford at the time. And he had met this young lady whose name was Sarah. He shared her name with us, and he evaluated her in a hospital. And because Down syndrome had just been discovered to be due to trisomy 21, and she had an organized pattern, he wondered if maybe she also had a condition that might be detectable by analysis of chromosomes. So he took a blood sample from the hospital, went back to Oxford, and his cell biologist found the extra, what they called then extra E group chromosome. And trisomy 18 was born as a distinctive syndrome based on one child at first. So here's Dr. Edwards himself in 1990 at a soft picnic. That's his wife on our left, his right, and that's Kyle down there In the middle of the picture, he has trisomy 18 mosaicism. Kyle's now in his early 30s. And Dr. Edwards came to the SOFT meeting at St. Louis and gave us a presentation at that time. Dr. Edwards sadly passed away a few years ago, and I had the honor again of writing an in memoriam for him in the American Journal of Medical Genetics, if you'd like to read that. So here in this panel up in the top right is Carey and Rachel. Carey's on the right, Rachel's on our left. The first two children, who were both about 2 at the time, whose mothers created the support organization for trisomy 18-13 and related disorders, SOFT, in 1979, incorporated in 1980, and that was on the Holidays Home in 1979. Down on the lower panels, another young lady whose picture is also depicted in Jordy's textbook of medical genetics, and she has trisomy 18 and displays some of the characteristic features, including the posture of the hands, which I'll show you about in more detail in a moment. In the upper left hand is a karyogram of trisomy 18. You can see of a boy with the X and the Y, and the 3 freestanding 18 chromosomes complete full trisomy 18. The lower right hand shows the picture of the characteristic hand with this index finger over the 3rd and the 5th over the 4th. The fingers are restricted in movement, camptodactyly, and this particular posture is quite characteristic, with very few syndromes having this posture. It's actually due to an alteration of tendon development that has been discerned through studies over the years. So here's a list of some of the more consistent and important manifestations, component manifestations of the syndrome. As I mentioned, 90% having structural heart defects. The hands plus the high occurrence of club feet means that some children would be labeled as having congenital contractures or arthrogryposis. About 5% of children with trisomy 18 have spina bifida, and trisomy 18 is one of the most common identifiable causes of spina bifida. And you can see some of the other more important structural changes on the rest of the slide. What confronts us the most immediately are the respiratory and feeding problems that occur soon after birth and make up some of what goes into the early mortality. These problems also coupled with the structural defects, especially those of the heart, or more rarely a congenital diaphragmatic hernia, spina bifida, and so on. You can also see that about 1/5 of children, usually not in the newborn period, but in infancy and toddlerhood, can have seizures. That was a topic of one of our talks earlier this week. But all of this, both the combination of the birth defects and the complex medical problems, really make up this matrix that involves kind of ongoing chronic disease issues that are related again to the early mortality that we're already been talking about. And that's kind of depicted succinctly on the slide here. As you'll see, this increased mortality, decreased survival in early infancy is very complicated. It's often made up of multiple factors, but especially apnea, under ventilation. More commonly, more importantly, in recent years, we found the important issue of upper airway obstruction. That is a topic that Dr. Glenn Green will talk about tomorrow in his presentation at 3 o'clock Central Time, if you can attend Dr. Green's talk. And then, of course, the last part is the cardiac defects fitting in as well. So all this goes into the next topic I want to summarize for you, and that is the population-based mortality studies, because I think it's important for us to have some sense of these figures, even in our helping families in their decisions about care. But first, let me pose a question to you. These are I have 3 continuing medical education questions embedded into my talk this year. And so I'm not going to call on anyone. You don't have to put the answer in the chat box, but I'll give you a second to think about the answer. And then, of course, you'll get the answer in a few slides. So the question is, what is the approximate 1 week survival in newborns with trisomy 18 and 13 based on these population studies that I'm going to tell you about in the recent decades of the medical literature? 10%, 30%, 50%, or 70%. So if you know the answer, just note it. Otherwise, we'll go on. So there have been 10 population studies that have appeared since 1985 in the UK, in Europe, Australia. And these studies had rather similar findings for survival and survival to 1 year of age, survival to 1 week of age, remarkably consistent in the median age, which I'll show you in a moment. More recently, there have been 2 studies, both published in 2016, one in JAMA, the other in the American Journal of Medical Genetics, that showed much higher survival to 12 months of life, and we will also talk about them. Notice these population studies are ones that have derived a denominator in a defined population geographical area with a well-characterized numerator. So I think they reflect real risk much better than hospital-based single institution studies. So these studies have shown that about 50% of children with trisomy 18 will pass away in the first or survive in the first week of life. The range of survival is 25 to 60% in these 10 studies. The survival at 1 month and 6 months, then similar figures, survival to 1 month, survival to 6 months, survival to 1 year is on average about 6% with a range of 2 to 8%. But of note, median survival was often in single digits, but ranged from 4 to 14 days. So the middle child in the study, if it was a study of 64, like our Utah study, the 32nd child, that would have been the median age of death, what that number would be. By the way, the last slide also said that there are fewer studies on trisomy 13, but their figures are remarkably similar. Then in 2016, Dr. Robert Meyer from University of North Carolina and co-authors from 7 other states, including the CDC, published a study in the American Journal of Medical Genetics with the largest series by far, over 1,000 children with trisomy 18, almost 700 with trisomy 13. Most of the previous series I mentioned had figures of 1, 2, or 300 in their N. So they had much larger series, and they showed higher 1 year survival in trisomy 13, 11.5%, in trisomy 18, 13.4%. What was also quite interesting and unique, because this had not been studied before, was that 5 year survival was not very different, so that about 90% of children we expect who live to a year will live to 5 or older. So there really is something about the first few weeks, something about the first few months, something about the first year in what goes into care and possibly in considering intervention. In July of the same year in JAMA, Dr. Catherine Nelson from Canada in Ontario produced a somewhat similar study, had a lower N. Here there were 174 kids with trisomy 13 and 254 with trisomy 18, but they had remarkably similar figures. The 1 year survival in trisomy 13 was 19%, actually higher, and the 1 year survival in trisomy 18 was quite similar at 12.9%. So both of these studies, the Meyer and the Nelson study, showed a doubling of survival compared to the previous 10 works. So of course, the answer to the question, are trisomy 18 and 13 uniformly lethal? The answer, of course, is no. The survival now in the more recent studies with higher numbers shows survival that's higher than 10%, 12% or higher, as I mentioned. I'm going to talk about trisomy 13, then I'll go back to the neurodevelopmental outcome piece. Before I do that, though, let me just mention that this seminal work in Japan by Dr. Tomiki Kosho and his colleagues at Nagano Children's, in my mind, really launched this emerging dialogue that's been going on now for about 15 years, very consistently and very widely in the medical literature. There was so little written prior to 2006 about these issues in particular. But what Dr. Kosho did, he's a neonatologist and a geneticist. He offered all the families of trisomy 18 the full care if they chose to do so at Nagano Children's during this time period. And they all did choose full care. And what he showed was that median survival was, rather than 8, 9, or 10 days, was 152 days, and that 1/4 of the kids, or 6 of 24, survived past a year. So while the numbers are smaller compared to what we were talking about in the other studies, he did show that full intervention, by the way, which did not include cardiac surgery because he did not have a cardiac surgeon doing infancy surgery at that time. Now he does, but he didn't have it at that time. So this did not include any role of cardiac surgery. So I think that that really launched the question, launched the theme of something that we really didn't know about till recent years, and that is, does medical intervention, in fact, improve outcome and survival in trisomy 13 and 18? And in particular, we've mostly been talking about survival here. So we wrote an editorial together in 2016 saying that, in fact, his study was the beginning. And then with the changing survival figures in the US and the UK, and then the recent study by Meyer at that time, and the cardiac surgery studies that had been emerging primarily from Japan, all suggested that medical intervention does, in fact, improve survival within outcome. So let me talk for a few moments about trisomy 13, a distinct syndrome, but a lot of the same issues will surface. Live-born prevalence is about half of trisomy 18, about 1 in 12,000. The phenotype is more recognizable than trisomy 18 because of the notable orofacial clefts in 65% of kids, and the severe underdevelopment of the eyes also in about 2/3 of kids, and the extra digit or polydactyly also in about 2/3 of kids. And here is the first patient described by Dr. Patel in Lancet in 1960. You may know that the two papers by Dr. Edwards and by Dr. Powell, single case reports of great importance, were back-to-back in one April issue of Lancet in 1960. This is Dr. Patel's patient who had, as you can see, the orofacial cleft and microphthalmia. This is one of my friends of many years, Aaron, from the Chicago area, who I met at SOF conferences over the years. Here he is in his walker. I think he's about 8 or 9 in this picture. He's also, his family was kind enough to allow us to include him in Jordy's textbook of medical genetics. So here is just a shortened list of some of the important, most common, consistent birth defects that occur in trisomy 13, the kidney, the holoprosencephaly of the brain, of course, the heart defects. So here's a question for all the clinicians in the audience. Hope you've already gotten the answer from the previous slides. What is the most distinguishing and helpful physical feature aiding in the diagnosis of the newborn with trisomy 18? So low birth weight, the small overfolded variations of the ears, the overlapping fingers, or the ventricular septal defect. So I should ponder that for a few seconds. And of course, recall that I showed you the picture of the overlapping fingers. So I'm going to switch gears now and still talk about natural history and then move into discussion related to development. But this picture is more than a placeholder. It's a reminder of this young lady with trisomy 18, who in this picture, she's in her late 20s. She's from Sweden, and for a number of years, she and her family, including her younger sister, who's there on her right shoulder, that young woman is now an orthopedic surgeon in Sweden. They came to SOFT meetings for many years. You can see how socially engaging she is. She's able to relate easily to everyone, very social, able to feed herself. She wasn't able to walk independently, but she was very adept at cause and effect and working her TV and other aspects of her daily life. So let me talk a little bit more about natural history, tell you something about what we know about older children with trisomy 18. I can't resist showing a picture of my friend Aaron on the left there. Aaron, he happens to be from Salt Lake City. I've known him since he's an early infant. Now he's 11. And you see he had his cleft lip repaired. And Aaron is always a socially engaging child. If anyone was at the Parade of Stars the other night, he was one of the stars. So it turns out that there are a sparse number of actual well-documented case reports of older individuals with trisomy 18 and 13. There's in fact only 15 case reports of well-described individuals. And this is sort of meant to help give you some spotlight or some snapshot of that. 5 of them had a skin biopsy trying to determine whether they could have mosaicism. 14 were girls, 1 was a boy. 1 of the children walked unassisted. But Dr. Kosho, again, from Japan, has a paper in 2013 of 2 children who walked unassisted, both at about 5 years of age. And I know other children through SOFT who walk unassisted, and some people in the audience know those children. By the way, I can't resist showing Christy's picture there on the left. In SOFT, there are more than 30 individuals over the age of 10, in fact, more than 20 individuals over the age of 20 years. So here, for those that are not familiar with the support organization for trisomy 18 and 13, here is the US webpage, very easy to remember, trisomy.org. The schedule of all the talks are easily available there. And then there's the SOFT UK, which also has many excellent resources. So some of my families and friends from SOFT, I'll introduce you to here just to give you kind of a feeling of some of our SOFT conferences in person. This is Stacy Van Haraway. That's her parents there, who are the presidents of SOFT, Barb and Steve. And Stacy in that picture was in her 20s. She did sadly pass away a few years ago in her mid-30s. Here, a picture of there on the right is a young lady, actually from Utah, who I helped take care of for a number of years, and young man from North Carolina on her right, Joey, who is one of the longer surviving young men that I've known with trisomy 18. Joey lived into his late teenage years. There's Aaron again. Can't resist showing his pictures. There he was on the left when he was a littler baby, and then similar picture to the one I showed you on the right there. And here's my friend Luna, who living with us in Utah, getting her medical care now, but from Aruba. There you can see 2 pictures, and I can actually visit Luna tomorrow at our children's hospital. Children with trisomy 13 or older, there are only 15 reports. You can see they range from 30 to 32. The oldest person I know is 36. In the literature, none were able to walk, but we know of 3 children who have walked independently with full trisomy 13. 1 was reported in Bonnie Beatty's paper in 1994. But I want to point out that one of my fellows, Amy Lebedoff, and I just recently published a paper in the American Journal of Medical Genetics on 11 adults with trisomy 13. That paper, as I mentioned, is in the American Journal of Medical Genetics. In the Living with Trisomy 13 group, also linked to SOFT, there are more than 20 people we know that are over the age of 18 with trisomy 13. And there's my friend from California with his mom that I knew from meetings at SOFT. And there's Aaron, who I showed you in the black and white picture when he was a little bit older. Again, you can see his social engagement. So let me spend another moment or two on, after my little photo essay there, on neurodevelopmental outcome. Here is Megan at a younger age on the left and older age when she was a teenager, adolescent, and Megan is daughter of Anne and Frank Barnes, who are the curators of the SOFT registry, and the surgery registry is a particular highlight of that database. So Bonnie Beatty, myself, and a number of other colleagues put together a paper that was published in 1994 that tried to lay down developmental milestones and also what we knew about developmental testing in older infants and children with trisomy 18 and 13. So this was kind of a list of the Denver developmental milestones. You can see in both 18 and 13, holding head up on average at 9 months in both conditions, sat alone about 3 years in trisomy 18, a little bit less, 3 years in trisomy 13. And this was a compilation of the developmental quotients that we were able to obtain from different centers and from families around the country. Here, just to highlight this for you, in children who are 3 to 5 years of age, trisomy 18, trisomy 13, their chronological age was a little bit less than 4 on average, 44 months, 46 months. Their developmental age, when put together, was 7 to 8 months. However, all of the children were able to carry out skills that occur in children that are older than a year, like feeding oneself, knowing cause and effect, and so on. So all this was their overall developmental quotient, brought down by expressive language and by motor skills, both of which are a challenge. Their actual overall skill level was better than this numerical score. Some other young infants were kind enough to give me a snapshot from a SOFT picnic a few years ago. So let me spend the last few moments, want to leave at least hopefully 10 minutes for questions at the end. So I probably will go a little bit quicker through some of these other slides so I can make sure that we have some time for discussion. But I want to just spend the last few minutes talking about why there is the controversy, or at least what might be the basis of why there would be any controversy. Certainly here we have a condition that's relatively common, one of the most common multiple congenital anomaly conditions, trisomy 18, high up on the list, trisomy 13, yet our usual approach to care is in fact not to apply technological interventions like ventilation. Certainly that varies. I already told you about the paper from McGraw and Perlman in Pediatrics of 2008, which laid out some of the issues. I'm going to show you those in a slide in a moment, but I want to point out 2 other important papers, one by Kugler and colleagues, published in the Hastings Center, which you're all familiar with, I suspect, bioethics report. And what they did very eloquently, and I refer this paper to you, is they really laid out sort of the arguments that are in the ethics and pediatrics literature about what are the arguments for care in children with severe life-limiting disabilities, and what are the arguments against actually intervening. So they lay them out quite eloquently and nicely. And lastly, I've already alluded to this, Lorenz and Hartart did the same. And I'm just going to summarize the issues. So I'm going to hopefully tantalize you a little bit with the idea of knowing more, even though we don't have the time, and this is not the right forum to be able to discuss this in as much detail as we'd like to. So McGraw and Perlman laid out some of the issues of parental autonomy, who makes the decisions, the best interest of the child standard maybe being our beacon, the difficulties in allocation of resources, and of course, what always comes around in all the discussions are, well, what about quality of life? What is the pain and the suffering that a child may go through, and how does that inform us in decisions that perhaps might lead to one saying, well, let's go down a comfort care route rather than applying any interventions and seeing where we go. But I think Lorenz and Hardart did a really superb job in just articulating all of them in great detail and actually suggesting sort of a plan of action really that might occur in a care conference in a nursery or in a PICU where you actually they sit down and kind of give you almost a guideline of where to go. But they also historically talk about, where the pendulum has swung toward parent autonomy in issues about where we don't have clear-cut answers. Likely the consensus is to let the parents be the primary drivers in the seat. But they also relate, compared to McGraw and Hill, all of the improvements in treatment, especially, of course, direction toward cardiac surgery, and the importance of support groups, and they mentioned SOFT specifically in the paper, the internet, social networks, and the whole disability advocacy trend in our society and where that fits into all of this. And they go back and point out Kugler's papers about the ethical justification. So the next few slides are about cardiac surgery, and I'm going to say that I am going to move through these quicker because I do want to have some time for questions. But I just point out the summary here. What I would suggest is we had a beautiful talk yesterday by Dr. Kosev on the topic, much more detailed than what I have here, and that's online next week. Please look at Catherine Kosev's talk, and also you can fast forward and look at this part of my talk. But this is basically a summary of the cardiac surgery studies of the last decade, and truly the bottom line is when you look at these studies, on average, 85% of children who had cardiac surgery with trisomy 18 and 13 left the hospital. That's a much higher survival rate than people were thinking about 10 years ago when we had no data. The SOFT registry currently, as Ann Barnes let us know just yesterday, has 103 children with trisomy 18, full trisomy 18, who have had cardiac surgery, most of those in the last 10 years, and 41 children with trisomy 13. Here's one of my favorite friends, one of our Utah kids, Ashton, who had surgery here at Primary Children's, a total VSD repaired not long after this picture on the left when she was approaching a year of age. Here's one of my other favorite friends, also from Utah, Sam, who actually now just passed his second birthday a few months ago. So question for you, the third CME question. There's no CME here, so this is just theoretical. What is the average discharge to home rate in children having cardiac surgery with trisomy 18, 13, of course, coming from these recent studies? Discharge to home rate, 25%, 45%, 65%. And of course, the answer is 85%. That's the average. So I'm just going to close with pointing out some work that's been done. Again, I'm giving you a broad stroke so that you have other places to go to look it up. But this was a paper that came out of an ethics conference in Denver that really discusses the model of shared decision making. Also, like the Lorenz and Hardart paper, kind of lays out in a table a script even of how professionals can approach parents with some questions they get asked in these particular scenarios. And this paper actually covers prenatal as well as postnatal decision making and management. So just in closing, the 2016 issue of the American Journal of Medical Genetics seminar series was entirely devoted to trisomy 18 and 13. Here are some pictures of some of our children and families. there on the cover of the issue. And in summary, just like to say, now I think we can quote that about 5% of children with trisomy 18 and 13 survive to 1 year of life. This assumes that maybe some of that is due to intervention, although that's not been demonstrated conclusively, and that most of those children who survive to the first year of life live till 5 years of age. Children do continue to progress in their developmental milestones, albeit slowly, but still do progress. And we talked about that topic. And then, of course, I'm going to emphasize that parents not only want to be, but should be a part of the shared decision-making process. And a lot of what I talked about here, as I mentioned earlier, was summarized in that paper in Current Opinion in Pediatrics. I also recently included a chapter in the book, Cassidy and Allenson, Management of Genetic Syndromes, that just came out this year in hard print. It's also available in e-version, and some other themes that I talked about today also came out in the other two cited papers. And here is a group of parents of kids with trisomy 18 at one of our soft picnics, one that was held in Utah. And if you go to the talk, when it's online, you'll see some of the key references that I mentioned about. And I'll just close with this piece by Busan, one of the patriarchs of haiku poetry. When I had the privilege of visiting in Japan, I came across this because I was there during the cherry blossom time, and it kind of resonated with me as having made me think about our children and families with trisomy 18 and 13. And the poem, the haiku, is "The end of spring lingers in the cherry blossoms." So I thank you for your attention, and I'm going to bring us back to the picture of the SOFT conference, or maybe we'll bring us off, right, Kelly, so that we can maybe see the questions there. Otherwise, we won't be able to see them very well. So we do have about time for about 10 minutes for questions. Kelly, did you want to take a look at those for me and help me
right now I don't see any questions in the chat or in the Q&A. So maybe hopefully somebody will put a question in as we're talking.
So while we're then waiting, maybe I won't go back to the slides, but maybe I'll go back to that discussion of cardiac surgery and just say a few more words about that. And then, of course, again, I'm going to refer you to Dr. Kosov's talk from yesterday. And also, of course, this talk will be online next week, and you can see some of those slides in more detail. But what it related was that there were very few reports of cardiac surgery in trisomy 18 prior to 2010. There was a series of 33 patients being operated on in a paper published about 11 years ago by Graham et al. That reported the outcome of 30 patients with 18 and 13. And again, about 85% of those children left the hospital. After that time, from 2007 to 2012, there were about 6 papers that appeared in Japan showing that children who had cardiac surgery, average age was about 9 months, but then it went down to 5 months. And what they showed in each of these studies, they were all series. They weren't longitudinal. There wasn't necessarily a control group, but when they looked at them, again, survival to 1 year was better in the children who had cardiac surgery than historically was known. In 2016, Dr. Kosov's paper appeared in Pediatrics. And then another paper by Peterson, a multi-team study, also appeared showing these sort of, again, results of surgery of different types. And again, showing that the range was 70 to 90%, but 85% of kids did survive. So an acceptable survival for a mixture of different heart lesions. certainly a higher mortality than an average child with a ventricular septal defect or an average child with coarctation. But I couldn't tell from Kelly's eyes if maybe that meant there was a question that had come up.
Yes, there are several questions. The first one is, do you think cardiac surgery will become more widely available in time, or do you think this option will remain only available at specialty centers?
I think because of the trend that's happening now with more and more hospitals offering the option all over the country. We know that Stanford University, we know that Boston Children's, of course, we know Nebraska still, even though Dr. Hamill's at a different institution. We know St. Louis University, but many other children's hospitals have offered it. I think that we will see that more prevalent. Now, of course, there are some hospitals that still decline, so a family may have to find that option at another hospital. And there are these hospitals I just rattled off that are willing to accept people. I don't know when and if we'll be in a position where all hospitals that have, all children's hospitals have that as an option. But when you look at the Cooper study published in 2019, more than 300 children had cardiac surgery, again, most in the last decade. So clearly the trajectory is upward. I think there still are institutions that will decline and I ideally offer to help the family transfer to another institution.
The next question we have asks about the role of augmentative communication in children with trisomy 18. Would improving expressive communication opportunities change the course of interventions medically and educationally?
So the beginning part of the question was the application of augmentative communication, right? Is that what you mentioned? So to me, that's very exciting as a prospect, just because we know that in other conditions, when augmentative communication and iPads and communication boards were applied, that children with other conditions would astound some of the field in what they understood or communicate than what we thought would be the case. So I, of course, would be a strong advocate for that being thought about and applied early. I think the second part of the question is a quite profound question, because I think implied in it is that if survival is, let's say, not for the moment part of the equation, but we're talking about developmental outcome, if in fact we knew that augmentative communication would improve language and communication, would that have an influence in how quality of life might be interpreted? That's a profound question. And I had not actually thought about it in that way. And I can imagine if we knew that augmentative communication continues to seem to have effects, we as counselors should be incorporating that somehow in our discussions. So thank you for that extrapolated idea.
And our next question is, has anyone studied the incidence of cortical visual impairment and hearing impairment in these children?
So hearing impairment is easier to say because there have been, even more recently, a number of children who have had routine hearing tests done, so that we know that narrowed ear canals in trisomy 18 can cause some middle hearing loss, but about 30 to 50% of children with trisomy 18 will have inner ear, that is cochlea or ear nerve hearing loss. And so, which could improve by hearing aids, and hearing aids should always be given as an opportunity if we do determine that an older infant does in fact have a sensory neural, that is inner ear, cochlea, or ear nerve. I do know of a few children in the last year with trisomy 18 where imaging of the brain was also applied to the inner ear, who had actually absence of the hearing nerve. I had not seen that reported until then, but it looks like it's still a rare finding, because in that situation, one wouldn't respond to hearing aids, where I think that most children do. The cortical visual impairment is tougher, because what that's really related to is not something that you can really measure like you can the hearing loss with a ABR. And really, it really is an inner ear problem, not just a processing problem. In the visual cortical, it really is kind of a processing problem, but it's my impression that usually gets better with time. That is, with time, the visual and attentiveness improves. Having said that, there are some kids with both trisomy 18 and 13 who have more involved birth defects of the brain that leave them with a more severe cortical. So on one side, a lot of kids who have it young, it clearly improves, young meaning first year of life. But some kids who have the birth defects of the brain, it really isn't something that's easy to improve. Thanks, Kelly.
Don't see anything else coming through, Dr. Carey.
Well, good. I thank everyone for the questions. All three of them are highly important and not with any clear yes or no answer. So I appreciate being able to think about them and discuss them. But again, I thank everyone for their attention. And as you know, Terry and Kelly mentioned, just like last year's virtual conference, all the conferences, both professional and those that were orchestrated for the parents, will be online through trisomy.org. And I look forward to the rest of the week. Thanks, everybody.